Chronic bronchitis is the inflammation of the bronchial tubes in the lungs, and what makes it chronic is the productive cough with mucus, which happens for at least 3 months each year for 2 or more years. Okay, so I'm Justin Prosimahos, and today with Ms. Daniela Conde, we will be discussing the pathophysiology or the disease process of chronic bronchitis together with its treatment algorithm and the medications needed, management needed to treat chronic bronchitis. Okay, so as what I've said, it is the inflammation of the bronchial tubes, which is in the conducting zone of the lungs. It is located at the proximal area, meaning it is near the midline where the trachea is located, and it is the two tubes that separates in the middle. And it is not in the respiratory zone or the distal areas, because if it is in the respiratory zone, it might be emphysema and not chronic bronchitis. Okay, so let's talk about the productive cough with mucus, which is an indication of chronic bronchitis. If it is a productive cough with mucus, it is chronic bronchitis. If it is a productive cough with pus, it is bronchiectasis. And those two are different because bronchiectasis can also be a complication of chronic bronchitis. Okay, so chronic bronchitis is an obstructive lung disease, which is why it is lumped under the umbrella of the chronic obstructive pulmonary disease alongside with emphysema. So these two are different but has some similarities also at the same time. So let's talk about first how chronic bronchitis is an obstructive lung disease. Obstructive meaning that the problem is that the air can't get out of the lungs, and it is restrictive if the air can't get inside. So in chronic bronchitis, in COPD, the case is that the air can't get out of the lungs. So another way of explaining is that, another way of discussing COPD is that the FEV1 to FVC ratio is lower. Okay, so the FEV1 or the forced expiratory volume per second and the FVC or the forced vital capacity is lower, which further gives us a much lower ratio of those two. So the usual is 80%. 80% the ratio of FEV1 and FVC, yung ratio nila is usually 80%, so that is already the normal. And if it is much lower, for example 50%, that is now considered as a COPD, which is a hallmark of chronic obstructive pulmonary disease. What I've said earlier is that chronic bronchitis is under the umbrella of chronic obstructive pulmonary disease along with emphysema. Now, are these two similar or different? They are different because chronic bronchitis is defined by its clinical presentation such as productive cough, and emphysema is defined by its structural changes such as enlarged air spaces. Okay, so how are they similar? They are similar because they often coexist and they have the same major risk factors. Moving on to the pathophysiology of chronic bronchitis, before we start, we'll have to talk about first the layers in the surface of the lungs. So in the surface of the lungs, we have the structure, just like in the skin, on how we have our epidermis and dermis. These are the layers in the normal lungs, okay? Normal surface of the lungs. So we can see there that there is the mucosal space and then the submucosal space. So it has the different layers there, but we will focus on the important one. So sa mucosal layer ng surface ng lungs, we have here the epithelium. The epithelium which the goblet cells are located. So these goblet cells are the one that secretes mucus, lumen of the lungs. Okay, so dito naman sa submucosal area, we have there the bronchial mucinous glands, which is the gland that secretes the majority of mucus into the lumen of the bronchi, helping to catch and filter the pathogens or the particles in the surface. So what happens is that when our airways or when our bronchi is exposed to these factors na meron tayo, the modifiable and non-modifiable factors, it could be smoking, the major risk factor, it could be air pollutants, dust, silica, or any chemicals, or even genetic factors that can trigger, that can be a starting point of chronic bronchitis. It can be a family history. Okay, so when our airways are exposed to these irritants and chemicals, it will cause a reaction, an immune response. So the normal immune response is that when the macrophages under the epithelium goes to the surface para hanapin yung foreign body, and of course magkakaroon ng immune response, maglalabas ng cytokines para labanan yung foreign body. So because of this immune response, nagkakaroon ng hypertrophy and hyperplasia. Okay, so hypertrophy and hyperplasia, which is the increase in cells, increase in the size of cells and increase in the number. So because of this hypertrophy and hyperplasia, makikita natin dito na there's an enlargement of the bronchial mucinous glands sa submucosal glands, and there's also an increased number of goblet cells. So this too is because of the hypertrophy and hyperplasia. Okay, so let's focus first here on the increased number of goblet cells. So what happens is that when there's a marked increase of goblet cells in the small airways, even the slightest increase ng mucus, nakakapag-cause na siya ng obstruction kasi nasa small airway siya. So once na magkaroon ng slight na pag-increase ng production ng mucus, ma-obstruct agad yung airway. Okay, so since there's mucus hypersecretion, magkakaroon ng air obstruction in the bronchioles. Then magkakaroon ng air trapping kasi hindi na makakalabas yung air kasi obstructed na siya. Okay, if this situation is prolonged, so pagpasok ng hangin, matastuck siya doon, matatrap, dadami, which is what leads us to the manifestation of a barrel chest. So this manifestation is usually present sa emphysema. However, nangyayari din siya sa chronic bronchitis if there is a prolonged air trapping. So to make the situation even worse, because of the irritants, especially smoking, yung cilia natin is nagiging short and less mobile. So it becomes short and less mobile, therefore making it dysfunctional paralyzed cilia. So now, it is dysfunctional, derailed na yung expectoration ng mucus. Derailed yung expectoration and elimination ng mucus, meaning yung cilia hindi niya na kayang i-move up yung mucus papunta sa throat natin para i-expectorate. So nahihirapan tayong ilabas yung mucus. So babalik tayo dito, there is increased mucus production na, di ba, because of the stimulation of the mucinous glands and then the goblet cells. So increase yung mucus production and hindi yung cilia natin is dysfunctional, hindi na kayang mailabas yung mucus. So patients with chronic bronchitis rely on coughing to expectorate the mucus, the accumulation of mucus. So we also have symptoms such as wheezing and crackles. So this is actually inspiratory crackles and expiratory wheezing. So why does this happen? So in crackles or rales, this happens because the airway is obstructed, and the air which is trying to get through that resistance, kapag na dumaan siya doon sa may mucus, nagkakaroon ng popping sound. Okay, so let us imagine that we are blowing into a straw in a glass with water kasi mucus is a fluid. So once we are blowing air, nagkakaroon ng bubbles. So that is like the popping sound. So that is why crackles is present, adventitious sound. Then expiratory wheezing. What does expiratory wheezing happens? Because the airways is narrowed, once the air passes through that passageway, nagkakaroon ng wheezing sound. And why is this connected to coughing? Because crackles can be relieved through coughing. Okay? So now, we have increased mucus production. What happens is nagkakaroon ng mucus plugs which blocks the airways. So when the airway is blocked, hindi na makakalabas yung air. So that is why we call this as an obstructive lung disease, di ba? Kasi nga the air can't get out. So once that the air is trapped inside the airways, nagkakaroon ng impaired gas exchange. Since hindi makalabas yung air, nag-i-increase yung partial pressure of carbon dioxide, and then yung partial pressure of oxygen is decreasing. Why? Bakit yung carbon dioxide yung nag-i-increase, hindi yung oxygen, and so on? So it is because yung oxygen is nagde-diffuse siya papunta sa blood vessels. Dapat mapupunta na yung oxygen sa blood. So since wala namang pumapasok na air kasi nga obstructed siya, so kulang na, nagde-decrease na yung number ng oxygen. While yung carbon dioxide hindi nakakalabas, so yung nade-diffuse from blood to the airway is puro carbon dioxide na. So tumataas yung concentration ng carbon dioxide in that airway, in that airspace. Okay, so that is why we have hypercapnia and hypoxemia. Hypoxemia because there is a decreased oxygen in the blood. Okay, so dito muna tayo sa hypercapnia. So in hypercapnia, nagkakaroon ng cyanosis. So cyanosis, why does this happen? So bluish discoloration because nag-accumulate yung carbon dioxide doon sa blood, which is dapat oxygen. Kaso nga lang, hindi nangyayari yun kasi mababa na yung concentration ng oxygen. Okay, so that is why we have cyanosis. And then, this is also the reason why patients with chronic bronchitis is referred to as blue bloaters because of the cyanosis, and it is in contrast with patients with emphysema na tinatawag na pink puffers. So it is different kasi sa patients with emphysema, hindi impaired yung gas exchange. That is why na-maintain pa nila yung partial pressure ng carbon dioxide and then ng oxygen. So increased partial pressure of the carbon dioxide also, tumataas yung carbonic acid sa blood. Okay, so tumataas yung carbonic acid sa blood, therefore causing the blood pH to decrease. And this is why we have respiratory acidosis. So another complication na naman siya. Kakaroon ng respiratory acidosis. So moving on, kasi nga mababa yung partial pressure of oxygen in the blood, meaning impaired na yung gas exchange. So what will happen is that yung blood vessels na nasa my airway, they will try to solve the problem. So what they're gonna do is magkakaroon ng vasoconstriction ng blood vessels to as an attempt to shunt the blood to other areas para makahanap sila ng areas na mas maayos yung gas exchange. So in localized infections or inflammations, nakakahanap sila ng area na mas maayos yung gas exchange. However, in some cases, severe cases, na malawak yung sakop ng ng inflammation, ang nangyayari is nagka-clamp down yung blood vessels kasi lahat na nagbabasoconstrict. So, pag mag-clamp down sila, nag-i-increase yung pulmonary vascular resistance, therefore causing pulmonary hypertension. So, let's look at the pulmonary vascular resistance first. So, let's imagine the normal blood flow in the heart. So, the blood will enter the right atria, then will move to the right ventricle, and then will transfer that blood to the pulmonary artery. Now, sa pulmonary artery, merong vascular resistance, which is normal. Merong pulmonary vascular resistance kasi rene-regulate niya yung blood na papunta sa lungs para hindi masyadong madami, yung sakto lang, yung kaya lang ng lungs ang mapupunta sa kanya para mag-circulate or para magkaroon ng gas exchange. So, that is why there is pulmonary vascular resistance. Now, increase yung pulmonary vascular resistance ng pulmonary artery, which is kasi nga merong pulmonary hypertension na. Merong pulmonary hypertension. So, ang gagawin ng heart, itatry niya na i-solve yung problem na to by increasing the pressure para ma-break yung resistance na yun, para makapag-transport pa rin ng blood papunta sa lungs. So, gagawin ng heart is increasing yung workload, especially sa right side. I-increasing yung workload ng right side of the heart, specifically the right ventricle. So, yung right ventricle, just like a person that is working in a gym, continuously and consistency, nagkakaroon siya ng muscle. So, yung right ventricle natin, because of too much workload or because of the increased workload, which is not usually normal kasi hindi naman ganun ka-intense yung workload niya before, nagkaroon siya ng muscle. So, nagkakaroon ng right ventricular hypertrophy. So, this right ventricular hypertrophy eventually will lead to failure. So, hindi na maayos yung blood flow kasi yung right side ng heart natin is nadadamage na, nagkakaroon na ng failure because that is not the usual task of the right ventricle. It is too much work for him. Okay? It is too much work for the right ventricle, the right side of the heart, which is why we have right-sided heart failure. Which is why we have right-sided heart failure. Okay, so we noticed that the problem started from the lungs. Diba? Nag-increase yung pulmonary vascular resistance niya, which causing pulmonary hypertension, and then because of an attempt of the heart na ma-break yung resistance, ma-solve yung problem, in-increase niya yung workload. So, nagkaroon din ng problem yung heart. So, from the lungs, yung problem niya is nagkaroon din yung heart. So this process is what we call the cor pulmonale. Cor, the heart, pulmonary, the lungs. So it is when the lungs is causing problem to the heart. So let's go back here to when there's vasoconstriction. So because of the decreased partial pressure of oxygen, meron nga tayong hypoxemia. Now, since decrease na yung oxygen na pumapasok, nagkakaroon din tayo ng hypoxia. Which is causing air hunger and dyspnea, which is also something that we can differentiate from chronic bronchitis and emphysema. Kasi yung sa chronic bronchitis, yung dyspnea is late na nagmamanifest, while in emphysema, early. Okay, so that's the difference between the two. So now we have hypoxia, meaning that the gas exchange is already impaired and the oxygen delivery process is compromised. There's irregular blood flow. So, ang gagawin ng katawan as a response is magkakaroon ng polycythemia. So, polycythemia, we have primary and secondary. So, sa primary polycythemia, the polycythemia vera, it is when the bone marrow yung may problem. Well, sa secondary polycythemia, ito na yung decreased yung oxygen sa body. So, what will happen is mag-send ng signal sa punta sa kidney para mag-release ng hematopoietin, which is the one that triggers the bone marrow to release more red blood cells. Okay, so i-increase niyo yung red blood cells, then magkakaroon pa ng hema concentration, which is also an increase in the blood components. So, if this two is present at the same time, if this two is happening at the same time, it is bad kasi magkakaroon ng increased blood viscosity. And the more viscous yung blood, mas mahihirapan tayo, mas mahihirapan yung katawan natin, yung heart natin, na i-pump yung blood kasi viscous siya. Okay, so, then, because of this, yung blood flow, hindi maayos, and then yung oxygen delivery process. Okay, so, an attempt na naman ng heart natin na i-solve yung problem na to, i-increase niya naman yung workload niya para maayos or ma-maintain, ma-regulate yung blood flow. Okay, so, which is again, leading to right-sided heart failure. Okay, so, let's go back to this part where the mucus plugs blocks the airways. Okay, so another complication is lung infection. So, maaaring magkaroon ng lung infections doon sa mga mucus plugs na yon, which will cause the release of purulent discharge. So, as what we said earlier, pag meron ng pus, that is bronchiectasis. So, another complication. Also, lung infection can cause exacerbation of the symptoms. Okay, so another complication is lung cancer. So we have here lung cancer, and this is actually an incorporated idea from Sir Romeo's pathophysiology. So according to my readings, hypertrophy and hyperplasia of the mucosal glands, submucosal glands, can also indicate a chronic lung disease, which is a risk factor for lung cancer. So it is important na if we have the diagnosis of, or before a chronic bronchitis is diagnosed, ma-rule out muna yung lung cancer kasi the hypertrophy and hyperplasia can also be an indication of a much progressive na disease. Okay, so that is the pathophysiology or the disease process of chronic bronchitis, and the treatment algorithm and the management of chronic bronchitis will be discussed by my partner.
So, for the medical, pharmacological, and nursing management, let's start with the factors that causes chronic bronchitis, and that is the viruses, bacteria, and the irritants such as smoking, dust. So, first, nursing management is to establish diagnosis and assess symptoms. For all patients with or without chronic bronchitis, we have to encourage exercise and healthy lifestyles, and the administrations of vaccines or immunizations, while for the patient that is still smoking, actively engage patient in smoking cessation. For the patient that chronic bronchitis is present, in the middle, treat airway obstructions with prescribed medications such as mucolytics, expectorants, anti-inflammatory, and bronchodilators, and educate the patient about this medication. So, according to the American Academy of Family Physicians, they have given the algorithm of pharmacologic management for chronic bronchitis, which it starts with the aprotropium adjuvant, a bronchodilator. And it shows here that when the patient achieves the optimal outcome using these bronchodilators, then the patient can continue with this therapy. But if there is only an improvement and the patient is not totally okay, then it will be added with the beta-2 agonist. Now, under the beta-2 agonist, we have two arrows here to show that if the patient has achieved already the optimal outcome with the pratropium and beta-2 agonist, then the patient can continue with this therapy. But if it is not achieved, but there are improvements, then continue with it, adding a long-acting theophylline. On the other side, if adding a beta-2 agonist does not change, there are no changes with the condition of the patient, then discontinue the use of beta-2 agonist. Instead, use a long-acting theophylline. However, if there are still no changes sa paggamit kay theophylline, then again, discontinue the theophylline and use the prednisone, which is a corticosteroid. Once there are no changes again, then discontinue the use of prednisone. Now, balikit sa baw-baw kung saan naging okay na si patient kay theophylline, then that means that the patient could continue with this therapy if the optimal outcome has been achieved. Then, pero if kung nag-improve lang o dili totally na naging okay si patient with the meds, then add the prednisone. Then if there are improvement, you observe that there are improvement with those pharmacologic management, then the therapy should be continued. Then next, we have to assess for the hypoxemia if it is present. Then prepare for the oxygen therapy, which is a ventilation, and educate the patient in using the oxygen. Then the nurse must assess the response to the therapy, such as visiting the patient. Now, if there are severe symptoms or decreased functional capacity, then refer to the multidisciplinary rehabilitation program. However, if there are no severe symptoms, then the nurse will provide periodic reassessment, lifelong monitoring, and care. Now, for the diagnostic test, we have 5, and these are the pulmonary function test, chest x-ray, blood test, electrocardiogram, and the culture of sputum. This pulmonary function test determines how well your lungs work and how much air goes into and out of your lungs, how much air goes from your lungs to your blood, and how well your lungs work during exercise. So chest x-ray naman, we have it is a radiographic which is commonly used but non-specific. Findings include hyperinflation, bleeds, diaphragmatic flattening, and peribronchial markings. Again, for blood tests may reveal mild polycythemia secondary to the hypoxia. Then, electrocardiogram findings can sometimes include supraventricular rhythm disturbances. Finding on airway biopsy include goblet cell hyperplasia, mucosal and submucosal inflammation, and increased smooth muscle. In culture of sputum, gram stain of sputum is often suggested as means of directing initial antibiotic therapy, but because of the likelihood of multiple organisms, the role of gram stain in acute decision making is de-emphasized. So, the presence of chronic bronchitis, I know, to cause worsening epithelial obstruction and deterioration in lung function. A large epidemiological studies have shown that chronic mucus hypersecretion was associated with a decline in forced expiratory volume in 1 second. But patients with chronic bronchitis symptoms had a 3-fold increased risk developing new COPD compared to the asymptomatic population. Those suffering from chronic bronchitis were found to have a higher levels of serum ILC reactive protein, which indicates that systemic inflammatory response could increase the risk of cardiac disease and other comorbidities. And chronic bronchitis increases mortality that leads to a lessened quality of life.